Welcome to this video lecture on intake interviewing. This video lecture is going to review what kinds of information you need to gather during the first session. Assessment does begin in the first session with the client. The tasks of the first meeting are to establish rapport and trust first and foremost, to review informed consent and the limits of confidentiality, to begin identifying collaborative treatment goals, to gather information about the client's history, to make an initial DSM diagnosis, and to do all of that in a relatively short amount of time. Intake interviews usually take longer than regular sessions and are billed differently. For example, intake interviews can take 90 minutes rather than a 60-minute session. Or if you are someone who does 45-minute sessions, you may be doing a 60-minute intake interview. During intake interviewing, you want to balance assessment with building the therapeutic alliance. So to do this, you take a collaborative stance rather than interrogating the client. It's important to focus on content and process. In other words, what the client is saying, and also how they say it. For example, if a client is talking about a traumatic event that happened to them, and they have a very blunted affect, that is important for us to notice and observe because it tells us about how the client is handling that traumatic event. We also want to consider whether we are going to take a structured or an unstructured approach to the interview. A structured approach is where you follow the same kinds of questions every time. Unstructured kind of weaves in and out just depending on what kinds of questions you ask initially, how the client responds to them, and then you'll figure out your follow-ups. Most of the time, intake interviews are unstructured. When I complete intake interviews, I find it very useful to have the client complete a psychosocial history and/or questionnaires prior to the session. I find this useful because you certainly can gain that information through direct questioning, but it just takes more time and is frankly more complicated because you can run out of time during the first session if you're going to just collect information directly through the interview. So usually what I do is I give a client a psychosocial history to complete before the session. I will then review it just before I allow the client into my office, and I will ask several follow-up questions based on what they have indicated. Interviewing varies by the therapist, though conventionally explores the following issues, and these are issues that you could also include in a psychosocial history: source of referral, presenting problem, mental health history, family history, occupational and educational history, and legal history. Let's begin with source of referral. We want to know who is referring the client. If they are self-referred, that may be very significant to pay attention to because typically self-referred clients may be more motivated to work on their own goals than a client who is referred by a third party. If the client is referred by a parent or a guardian, which is typically the case for children and adolescents because they are less likely to attend therapy on their own volition, not always the case, but often the case, we want to know what goals the parent or the guardian may have, in addition to the child and adolescent's goals. If the client is referred by their partner, we want to know what their partner may want them to work on, and we may even consider whether couples counseling is more indicated. If the client is court referred, this is the case for mandated clients, we want to know not only what the charges are and what they need to work on, what they're required to work on during counseling, but also what kinds of information does the court expect to be disclosed. That's important for us to know because the client should also know this so they can decide how much information to provide us with. Next, if a client is referred by an Employee Assistance Program or EAP, we should note this and also be aware of how many sessions the EAP is giving us. Most EAPs give a restricted amount of sessions, 4 to 5 let's say, and it's your responsibility to know that and communicate that to the client so that they know they only have 4 to 5 sessions. That's going to impact treatment goals, and if they want to continue, there needs to be a discussion about whether or not they want to do self-pay, or if you're doing pro bono, or if they want to use their insurance and do copays after those 4 or 5 sessions are up. That needs to be a conversation on the front end. If the client is transitioning from inpatient hospitalization or a residential setting to an outpatient setting, we want to wonder several things here. We want to know not only what were they hospitalized for or what were they in a residential facility for, we also want to know what were they working on during that time in terms of their own treatment goals, what progress was made towards those treatment goals, because often the goal of the outpatient therapist is to continue the work that was already done. If a client is referred by their school counselor, let's say, or a school psychologist, we want to know what issues have been going on in the school environment, academically, for example. It may be helpful to get this information from the parent, guardian, and the client, but it also might be helpful for us to receive a release of information from the client to talk directly to that school counselor. It's the same with a physician referral. We certainly want to know why their physician has referred them. We can ask the client that, but it may also be helpful for us to talk with the physician directly, and in that case you would need a release of information. After we have asked about the source of referral, now ask about the presenting problem. Why is it that the client has come to see us? We want to get the client's perspective on this, what current issues they have that they feel they need to work on. We also want to ask the client about what the perspective of others is about why they should be in counseling and what they need to work on while they're in counseling. A client, for example, may give you a presenting problem of, let's say, I don't know, depression, and when you ask about what other people think about that, it can much more deeply broaden your understanding of the client's depression. For example, they may say, well, their partner notices that they're very absent in their relationship. That may be very important to attend to as part of treatment. In addition, a client may identify a presenting problem that is only a partial picture of what's really going on. And so asking about what other people around them want them to work on, parents, friends, partner, children, co-workers, boss, probation officer, physician, any of those parties, can yield much more useful information in determining treatment planning. For example, a client may not mention substance use right off the bat, but when you ask what their boss wants them to work on, for example, they may say, well, I'm about to be fired at my job because I've been caught drinking on the job. That would be a treatment goal. After we have asked about the presenting problem and we've determined what those are, we also want to know the history of the presenting problem. We could ask when it began, how often it occurs. This has to do with the frequency. How long does it last when it occurs? This is the duration. How severe does it get? This is the intensity. Those kinds of questions can help us to somewhat understand the spectrum, if you will, to dimensionalize what the client is experiencing, and through that we can start developing treatment planning that's a bit more detailed, descriptive. We want to know how the client has coped with that issue before, and if they can think of a time when they didn't experience the problem. These are known as exception questions from solution-focused therapy. Those kinds of questions are very useful because we want to reaffirm and highlight, if you will, to reinforce what the client has already been doing, what's been working for them. Counseling is not about giving advice early on. We shouldn't be giving the client new tools without first asking what they've tried that's worked for them. It's much more effective to reaffirm what the client is already doing well. Once we've asked about the presenting problem and the source of referral, we want to ask about the client's medical history. Why do we do this? Well, it's very important to gather information about medical conditions because these are likely a component of treatment. If the client has issues such as chronic pain, gastrointestinal issues such as Crohn's disease, neurocognitive issues such as Lyme's disease that can cause cognitive slowing, same as HIV or AIDS, heart attacks or strokes, medications taken and why they're taking them, brain injuries, that can be quite significant. We want to know all of those pieces of information if there's anything significant going on medically. and we may need a release of information for a medical doctor in order to talk with their medical doctor more directly about these issues. It's also important to ask the client when they've had their last physical exam. I do this in all of my first sessions and all of my intakes. Well, why do I do this? It's because medical issues can sometimes mimic mental disorders. And if you don't ask or inquire more about what medical issues they may be experiencing, sometimes that they don't even know about, you may miss a very important piece of information. Here are some examples of medical issues that mimic mental disorders. Hypothyroidism and depression. Hypo, it means low levels of the thyroid hormone. Hyperthyroidism, that's high levels of the thyroid hormone in mania or ADHD, where you have increased energy. HIV or AIDS and depression or behavior changes, because again HIV or AIDS can lead to not only mood changes but also can lead to low energy level, for example, problems sleeping. Cardiac issues versus anxiety. We want to know if they have any heart issues going on, because the client may be experiencing, for example, tightness in chest, or arrhythmias, which are abnormal heartbeats, for example. And we may think, well, maybe that's anxiety or a panic attack, but we first need to rule out an actual heart attack, an actual heart issue. Next, we also want to inquire about brain tumors, or at least we should be aware that brain tumors can mimic psychosis. Here's an example. If the client says, I am smelling smoke at the moment, we may believe that they're having an olfactory hallucination, which has to do with smell, that they're actually smelling something that isn't there. However, it is entirely possible that they actually have a brain tumor, and the brain tumor is causing them to have that bizarre, unusual experience. So here you can see, if you don't ask about the physical exam and you don't prompt the client to get a physical exam if they haven't had one recently, and by the way, when you do that, you ask the client to get a full lab panel when they get their physical exam, because that will include things such as a thyroid check. You can miss some very important information. It would be, for example, bad treatment. It would be malpractice, really, if you had a client come to see you for depression, or at least depressive symptoms, and you didn't screen for thyroid issues, or at least have the client get checked out for those. The client makes no progress because they have a thyroid problem. And then later on, it's discovered they have a thyroid problem, and they've spent a lot of time and money and investment in an ineffective treatment. So that's why checking for medical issues is very important during the first session, and prompting the client to go to their primary care physician for a medical examination if they haven't had one recently. Next, we want to ask about mental health history. It's important to understand what the client's treatment history has been, whether they've seen any previous therapists, whether they have any current therapists or psychiatrists, that they may be in couples therapy currently, for example, or they may be receiving medication management. We want to consider here asking for any releases of information needed to contact their previous treatment providers, so that we can continue what they have done, or at least build upon the foundations of other people. That's one of the most important things that you will learn as a counselor over time, which is often, especially when you work in community mental health, those clients are not fresh to you, meaning, or at least that you won't be the only provider working with them. Even if you're the first, you won't be the last. Often clients will work with multiple therapists, or they'll work with other providers at the same time, and it's very important for you to understand your own role in their history of treatment. Okay? It's also important to understand that past experiences can inform treatment planning. So if you ask the client directly what they liked and disliked about past therapy experiences, what worked for them, you can build upon those and include those into treatment planning. You also want to be wondering if a client has seen multiple therapists in the past and has received no significant benefit from that, whether or not a comprehensive assessment would be helpful. In other words, if you want to give them a comprehensive test battery that includes a large personality assessment, that may be useful because there may be something that's being missed. Just like with medical issues, you don't want to miss a major psychological issue either. Once you've asked about the client's mental health history, next you ask about family history. Now note that family history is not the first thing you ask about. This occurs towards the middle of the interview, after you've asked about their presenting problem, the reason for referral, after you've asked for their mental health history. Now why is this? Well, you certainly could begin with family history, but the risk you run is that the client will perceive you as somehow connecting all of their problems to their past. And some clients, because of popular culture, will imagine that psychotherapy is still wedded to old school psychoanalysis, and basically assume that you're going to be, in the end, thinking that all their problems are a result of early childhood trauma, particularly their relationship with their mother. Now, of course, that's not necessarily your theoretical orientation, but the client won't know that. And so that's why you don't begin with family history first. In addition, it's difficult for some clients to talk about their family, especially clients from collectivist cultures who will want to defend their family. So you want to proceed here only after you've built some rapport already. It's important to ask about a person's relationship with their parents, their partner, and their children, significant people in their life. How are those relationships going? Are they strengths to them, and in which case they can become important support systems that could help them in treatment? Or are they problematic, in which case they may become treatment issues to work through? We want to ask also about family history of medical issues, mental disorders, suicidal suicide attempts, substance abuse or any addiction issues, and cutoffs. And cutoffs mean when a person doesn't have any concurrent or ongoing contact with a family member by their own choice. And why do we ask about those issues? Well, we want to understand, number one, about whether they have any predispositions, such as a family history of bipolar disorder. We also want to know if anything's been normalized in their family, such as family members completing or dying by suicide. We also want to know about any cutoffs, because that can tell us something about family dynamics and how the person is interacting with family members. When we get to occupational or educational history, we have already developed some rapport with the client. Now, the interesting thing about occupational or educational history is that for some clients, this is actually one of the major treatment goals. In my clinical experience, there are two major issues that a client comes to counseling for. One is relationship issues, and the second is job occupational issues. If a client is a minor, it's going to be school related, academically related. If a client is an adult, it's often work related. So it's important to ask about these issues, especially if it's one of the presenting problems the client has. If the client is a minor, you want to ask about their academic history, how they've done in school over time, what their current grades are, and how their grades contrast to their academic history. For example, are they doing, having a banner year, or are they really struggling this year compared to previous years? That would be important to note. If you're working with an adolescent, I also inquire about what their post-high school goals are. It's important because adolescents who have really strong goals often have the motivation to push through issues in order to achieve them, whereas adolescents who don't have long-term goals often feel lost and will engage in sometimes self-destructive acts just because they don't have any long-term goal that they're moving towards. So that would be important information to assess for. I'll also add that you'll work with some adolescents whose post-high school goals are unrealistic, and that tells you something about their maturity level. For example, I've worked with 16, 17-year-old boys who have wanted to be famous rappers, or they've wanted to be athletic stars, or they've wanted to be famous musicians, and sometimes they don't even play an instrument or participate in a sports team. So again, it tells you something about that person. If you are working with an adult, you want to know about their current job and satisfaction. That's always an important question to ask during the interview. You also want to ask them about their vocational goals, if they want to change their vocation or change what they're doing or change the setting in which they work, the kind of company they work for. You also want to ask, especially if the client has career-related issues, they come in with a career-related issue, what their job history has been. and how that's gone for them. If they want to make changes, it's useful to know what they've already had experience doing, because that can start tapping into what we call transferable skills. Once we've asked about all of the following, the reasons for referral, the presenting problem, their mental health history, their family history, their occupational issues or history, now we can start asking about legal history only if the client is referred by the courts or their presenting problem is related to legal issues. I don't think it's always salient to ask about legal history with clients unless it seems really pertinent to the case. You don't ask questions that aren't pertinent. And a client is going to feel judged when you ask about legal history unless it's a pressing issue. Okay? So here are some examples of when it may be important to ask about legal history. If there's substance use going on, because often substance use, particularly if they're illicit drugs or substances, can lead to legal interfaces with the legal system. If they're receiving sex offender treatment, usually there's been some kind of a legal interface with the legal system again. If the client is receiving treatment for kleptomania, they may have been caught stealing and got into legal trouble that way. There are, of course, other issues. Those are the main ones that you should be aware of. The following should be assessed during the first session by survey, interview, or both: suicidal ideation, homicidal ideation, substance use, trauma, abuse, neglect. Let's go through those 5. Remember, before you ask about some of these, for example, suicidal ideation, homicidal ideation, abuse, neglect, you need to have had that conversation early on during informed consent about how there are some limits to confidentiality. Because if you have a client who tells you, yes, I'm indeed suicidal and I have a plan to end my life, they should know that you have a responsibility perhaps to tell a third party about that. They should know that ahead of time. Okay, so the client isn't surprised when you then say, well, I actually may need to talk to someone else about that. Now, if you're using a psychosocial history, and you have items on there about those 5 areas, and I absolutely recommend that, you should be following up during the interview. You should absolutely make sure, for example, if a client has checked the box of, yes, I have felt suicidal in the past week, that you follow up on that and ask more to make sure that the client is safe, to go through some basic safety contracting if you need to, or safety planning. So suicidal ideation and homicidal ideation, those 2 are important because they have to do with risk. We want to ensure that the client is not at high risk, or if they are, that they either have a safety plan in place or that other measures are taken to keep them safe. Okay. Next is substance use and trauma. Those 2 are very important to ask about either by survey, interview, or both, because and the client, by the way, will not always endorse this. For example, they may have active substance use issues or trauma issues that they're not willing to talk to you about. But regardless, you should be asking about them because those 2 issues will interfere with treatment. If a client has an active substance use problem, they're going to have some difficulty with attending to other issues that are part of therapy. And if the client has a trauma history, they may be only able to make small progress towards other goals because the trauma can be fairly large. It can loom large in their lives. So I give you an example. Let's say you have a client who's self-injuring, and your goal is to work on self-injury, and there's a trauma history that you haven't asked about. Often the client is self-injuring because of symptoms of trauma. Okay. Abuse neglect is important to ask about. Not only do you have a reporting requirement there, and the client should be aware of that legally, you have a reporting requirement, but in addition, if the client has experienced abuse or neglect, even if they haven't been traumatized, it may well play into their relationships or some of their presenting problems that they have now. By the end of the first session, we should discuss with the client a summary of the interview, what the client has said to us. They need to receive that just summarization. That would be helpful to them because they feel heard and listened to. Then you move into a discussion about treatment goals. What treatment goals does the client have? What goals do you have? And then you collaboratively come together and figure that out. Any referrals that you feel like would be useful. So, for example, if you believe the client would benefit from psychotropic medication, or that they need to visit someone for a comprehensive psychological assessment if you don't do that, that would be useful. It's also helpful to gain any releases of information, by the way, if you do need to talk with another treatment provider. You do that towards the end of the session. You also want to go through your plan for the next few sessions. For example, if your plan is to do 4 sessions of assessment, it's important for the client to understand that so that they're not surprised where you continue to ask more assessment related questions before working on something more directly through therapy. It's also helpful if you do know your treatment approach for the client to know that ahead of time. And then finally, you want to ask about the client's own experience of the interview. The client will share with you what it was like for them, and then they'll also give you some feedback about how you can tailor your approach to best fit their needs. That's a very important first question to ask, because sometimes clients do want a certain way in which you interact with them, and allowing them space to talk to you about that helps to build trust and rapport. So, we're at the conclusion of this video lecture. In review, in the first session, you should be inquiring about the source of referral, the presenting problem, the medical history, the mental health history, the family history, the occupational and educational history, the legal history. Then conduct a general screening for risk, barriers, such as, for example, substance use or trauma, barriers to treatment, and any reporting issues you may have, for example, abuse or neglect issues. And then close with a summary, collaboratively identifying any goals, making referrals if needed, getting any ROIs if you need those, planning for next sessions, and also inquiring about the client's experience of the interview. That concludes this video lecture.